everybody. Good morning. Great. Good morning. I'm Sally Warren, the Director of Policy here at the King's Fund, and I'm delighted to welcome you to this morning's breakfast event on the NHS workforce, and particularly well done to those of you who have managed to battle in through train strikes and problems on the tubes to be here with us in person, but we are also being live streamed to the audience who had been invited to join us today. So please be aware that we are being joined by people beyond these four walls. But I just want to say thank you so much for coming today. Obviously, 2023 was the year of the long-awaited NHS workforce plan, so we thought it would be a great opportunity to be able to spend some time reflecting on where we are in the workforce in the NHS, and in particular, really thinking about how we can focus on retention of our current staff and our future staff by really thinking about how the NHS can be a really attractive career, how we can think about staff wellbeing to mean that we are not only training more staff but also retaining the skills and expertise and values of the staff we have. So I'm hoping today will be a really useful discussion where we get to hear reflections from a national policy perspective, a local delivery perspective, our King's Fund perspective on staff wellbeing and culture, and then Steve will bring some perspective from Parliament as well in terms of his role from the Select Committee. So how today will work is we'll hear from each of our panellists with some opening remarks. I will then kind of follow up on those opening remarks with a few questions, and then we'll come into the room for any questions or comments or reflections that you all may have. And we have roaming mics for that, so we'll do the classic hands up. And if you can wait for the mics to come to you before asking questions, then particularly those who are watching via live stream will be able to hear all of your questions. I did want to, before we kind of get into some final housekeeping points before throwing open the event fully, I did want to just say a few words about social care and the social care workforce. So today is an event primarily focused on the NHS as an employer, the NHS as a place to work. That's not to say that social care doesn't have huge challenges in the workforce, but also huge potential in terms of the careers social care can and should be able to offer. But today we are focusing on the NHS. We will continue to do work here at the Fund on the social care workforce. So we're currently doing a project on how social care can and should attract younger people into the workforce as one of the key areas of potential growth for the sector. But I did want to kind of deliberately say this is an event about the NHS. This isn't because social care isn't important, particularly in a week where the government hasn't been delivering a long-term workforce plan for social care. It's predominantly been assuming it can use immigration as a way to support the social care workforce, and yet this week we've seen the government decide it doesn't want to use immigration the way it has in the last year, but without an alternative strategy about how we can pay staff enough in social care, reward them, value them, and really help recruitment and retention. So I wanted to acknowledge that the social care workforce challenges are very significant. We will look to do more work in the King's Fund as well to support the sector. But as I say, today is predominantly about the NHS, but I'm sure we will end up talking about social care because future careers will inevitably blur across those boundaries. So it's likely to be a feature of our discussion as we talk about culture and retention throughout this morning. But a couple of final bits of housekeeping before we start to get into the substance of the day. The first to say is, for those of you who are in the building, we are not expecting a fire alarm. So if a fire alarm does go off, it is for real. So please do follow either the signs or a King's Fund member of staff, and we will get you to the kind of areas that you can wait. If you are using any social media, the hashtag is NHS Workforce KF. So please do use that as we go. I've already mentioned that we are being live streamed. Also to mention that there are some journalists both in the room and on the live stream. So any contributions, comments, questions you should consider as being on the record. So hopefully that was all in the information provided to you in advance, so that shouldn't be a surprise to anybody. But great. So I think that was all of the housekeeping that I needed to go through. So I wanted to start by introducing Navina to talk to us about the workforce plan as a whole and where we kind of are now in terms of you finally got the document published and now really the hard work starts to deliver it. So Navina, thank you so much for joining us.
Thank you, Sally. I will try to be really brief. There's a lot I could say about the long-term workforce plan. First off, I have to say it is truly historic. It is really exciting. It is extremely ambitious. And it is the product of very hard work from many, many stakeholders, including King's Fund and others. And I really want to thank everybody who contributed to it because there was a lot of kind of rigor, a lot of sort of kicking the tires on it and everything. So what we see now is something that is really bold and ambitious. It is very difficult to, well, it's timely. I think it's really timely. So when it was commissioned, we took about 18 months to create the plan. And right now, I think it's a really important step in thinking about the future. Post-pandemic, where we are with how staff morale is, where we are with working with the backlog of care that's required, all the pressures on our staff and our systems. You mentioned social care. So it is something that we can really come together to build, not just for the future, but actually right now. It covers 3 areas: train, retain, and reform. It's controversial. I'm sure we will get to discussing some of that. The other thing I want to say is it's iterative, so we will be going back to reporting on our progress and also thinking about what it should look like going forward every 2 years. So we're already starting to think about the next version and what it would look like and what it means. In terms of delivery, it's 4-5 months on now. We had met with stakeholders in November. A lot of stakeholders came together again to start to look at what we need to do next. So in retention is already something that's been happening, and we've been discussing this, and we have had a real focus work on retention at the provider sector, at the point of care, and we're beginning to see some of the positive outcomes of that. We can talk about that in a minute. So really, that's what everyone's really focused on, and that means looking after our staff. That's mean putting into place practices which we see all the good things happening for retention. It's happening somewhere in the NHS. So it's about making that something that we can spread and do flexible working, all of that sort of thing. So retention is key. In terms of training, we've got our training numbers ready for 2024. The big expansion will be in 2025. So we're working with the Universities UK, with our placement providers. We need to look at our educator workforce. So we're definitely focusing on that as well, but also new ways of learning. I'll just mention 2 areas in the reform space. We are looking at what the future teams are going to look like. So new roles are really important. We have roles that are already, we call them new, but they've been around for a long time. So it's really now refining their scope. There's some roles, we've got regulation coming up for our associate roles soon with the GMC. So, there's quite a lot happening in that space. There's also reform in the education curricula and the training for our postgraduate trainees. Many of our junior doctors or doctors in training have given us a lot of feedback. And it is time to kind of really think about what the future of training can look like. It doesn't have to look how it did 10 years ago, because times have changed and opportunities have changed and the way we learn has changed. So those are really important things. The final thing I will say is you're absolutely right about social care. And when we work really closely with people at the point of care, like Matthew and other colleagues, there's a lot happening and a lot of innovation and really good partnership working happening already at social care, around workforce, around training and education, around shared roles and all of those sorts of things. And really, sometimes at the centre, we run to catch up. However, government did commission the development of a strategic framework for health and for workforce planning for health and registered social care, which we have worked with Skills for Care and others, partners like yourselves, to develop. So that should be out soon. So that will help us to think together in a kind of productive way, I think, about the future of our combined shared workforce.
Thanks very much, Navina. So I think a real sense of the breadth of what's in the long-term workforce plan, but also particularly on some of the things around retention, that it is already happening in places. So there should be hope for leaders and for staff in the NHS that that future is attainable, it's possible. It's just how we make sure it happens across the piece rather than in patches. So thank you, Navina. I'm now going to jump to the other end of the armchairs to Steve. So Steve, thank you for joining us, Chair of the Health and Social Care Select Committee. Really to hear your perspective from a parliamentary position on the challenges and opportunities around retention in the NHS.
So thank you for asking me. A timely event, both in terms of 6 months on, but also in terms of end of the year, time to reflect on, I would say, opportunities and challenges. So the Select Committee that I now chair is obviously chaired by the Chancellor before me, produced a major workforce report, and obviously I endorse that. Looking across recruitment, training, retention. So the main conclusions of that report were pretty stark. We found the NHS and the social care sector, which I'm afraid we do have to constantly talk about, were facing the greatest and are facing the greatest workforce crisis in their history, which will come as no surprise to anybody. We argued that the best way to address the challenge was for the government to do proper workforce planning, independently assessed. Therefore, so the long-term workforce plan published just before the summer was a huge, I agree, it was a huge step forward. I mean, we constantly talked about the much awaited, the long awaited, the much wanted workforce plan. So I think it is a real sign of hope, actually. I think it's a sign of hope for patients and families and staff who work in the NHS, and maybe we'll talk about industrial action later, but one of the big asks of the BMA was that there was proper long-term workforce planning. There now is. They seem to have moved on to something else, but we'll come on to that. So in terms of specifics in our report, and what the government has sort of done with it since. So one of our key recommendations was the number of medical school places should be increased by 5,000 to around 14,500, 15,000. That doubles medical school training places in England to 15k by 31-32, which is extremely welcome. There was some question when we had our initial evidence session on the workforce plan that we wanted, some medical schools were ready to move now, and we wanted them to be able to do that. So Worcester, quite a lot of lobbying from them. So I think it's regrettable that the government was inflexible in terms of money being in place to go for this September. But it's good that what's in place. So I had raised that with government quite a few times, and it would have been a good signal of intent, I think, to get some stuff ready from September 25. But anyway, in terms of future-proofing the workforce, I think the emphasis on training is really strong, but the detail is lacking on retention, if I'm honest. I think the report noted that the pressures on the workforce were having a real human impact on the people involved, and we obviously hear that every day through our work, and our frontliners will hear that obviously more than I do. And the result of that burnout is a massive, massive impact on retention, which is then a vicious circle, increasing the pressure on those who do remain, who then burn out even more themselves. So I think if we're to make health a more attractive career, that's where political attention must be alongside pay. The committee's report set out a number of recommendations. So we called for flexible working arrangements in all trusts, with a view to ensuring that all NHS staff have got similar flexibilities in their working arrangements. We talk about a renewed focus on retention with improved flexible working options, end quote. And there's quite a lot of detail still to come on that. We've got the Secretary of State before us next week, so that's one of the things that we'll be talking about. But I think the government was listening to the committee on that point. And I always make this point, and I will, because we've got trusts in the room and on the panel, it's not just the responsibility of government and NHS England to retain staff. The direct employers are the trusts. And it can't always just be, if the government weren't beastly, then people wouldn't leave. I think that's a lazy answer, quite frankly. We also called in our workforce report for reforms to the NHS pension scheme, the number one ask of the BMA, which the government bit the bullet on in the spring budget this year. And that was a difficult thing to do, right? You're effectively giving a tax cut to some of the better paid people in our country. It was a difficult thing to do, but it was the right thing to do. It was something that Jeremy had called for when he was in my job, and then he made happen in his job. On social care, because I'm gonna touch on it. I'm sorry, but the NHS workforce cannot and will not succeed if that challenge isn't gripped. We noted, without the creation of a meaningful professional development structures, better contracts, and I think a long-term workforce plans for social care, which I know NHS England and the government sigh, let alone number 10, sigh incredibly deeply when I say this, but I think it has to happen. And we're going to be stepping up our calls for that, seeing as we've been reasonably successful in our calls for a long-term workforce plan for the NHS. As I said in the House this week, the number of vacancies in social care are down from 164k to only 151,000, which in large part was due to the number of care workers coming to the country as part of the Shortage Occupation Scheme. So, as I said in the House on Monday, and some of you will have heard a rather robust interview I did on Channel 4 News on Monday night, I'm extremely concerned about the changes to family dependent rules. The government's line will be, and is, that there is pressure on public services, there are pressure on the school places, although every school in my constituency has got a falling role and would love some more pupils, and there are pressure on doctors' places, etc., etc. And their changes will not impact on those coming to work in the social care sector. It'll only be on those that would come as dependents with them. I struggle to see the evidence and the workings out behind that, and I've given the Secretary of State notice that I'll be asking her that next Wednesday. If they have evidence to that effect, an impact assessment to that effect, then I'll be more than willing to hear it. But my instinct is that it's a global workplace, and people will choose to go elsewhere instead of coming here. And I hear the argument around a homegrown workforce, and we want jobs in that sector for our people. Well, yeah, okay, fine. But when I go into schools and colleges and universities, I don't get a big show of hands of people who want to work in social care. But even if you did, that isn't going to happen overnight. And I think that it's a huge challenge, what was announced this week. We are very worried about it, and we will be raising it with ministers. Just in conclusion, I suppose it was reassuring in the King's speech and autumn statement that the government reiterate their commitment to delivering the plan. We're going to continue to scrutinise it. Obviously, it depends how long this Parliament runs. I'm slightly concerned that if it were to be a spring election, we're pretty much done at the end of February, which is a worry. But we're still in the early stages of the plan, and that's what people have to remember, is that just because it was announced, if announcing things from Downing Street was the answer, then the Blair government would be the most successful in history, and so would every other government. So it's a practical delivery on the ground. And just my final point would be that we've done work on ICSs, we've done work on digital NHS and industrial action, and this comes into that, as does migration. There is a productivity assumption built into the long-term workforce plan, which everything is dependent on it hitting. The NHS has never hit the levels of workforce productivity that is built into that plan. It greatly worries me that the assumptions are all built around that, and without a proper understanding and a proper development of the digital offer, and making sure that you don't have to log into five different systems to enter your computer system in certain trusts, then that productivity isn't going to be reached. I think that's a real threat to the workforce plan. But that's my opening thoughts.
And not just a threat to the workforce plan, but a threat to patient care, actually, if we can't get some of those basics right.
They're the same thing. Yeah,
yeah, exactly. So I think absolutely on social care, completely right to be asking for an impact assessment. It will be fascinating to see what the government believes the impact of this week's announcement will be, and what steps it will be taking to mitigate that impact. But I think was kind of part of your challenge, Steve, was saying it's not just the responsibility of government employers, government and NHS England to tackle retention, it's employers as well. And I think everybody in this panel would agree with that, but it's not only the responsibility of employers as well. All of those partners play a role. But it feels like that's a good segue to Matthew, to hear from you about, you're trying to do this day in, day out with your team. So what are your reflections on retention and supporting the workforce?
Sure. Hello everyone. So I'm Chief Executive of Barking, Haven and Redbridge in North East London. So we employ around 8,000 people, and we deliver care in one of the most deprived parts of London, actually a really interesting part of London to work in. And I'd agree with a great deal of what Steve said, and also very much support what Navina said about the importance of the workplace plan. So our big focus at the minute is on retention. You know, recruitment's a really important part of it, and to give you some context, we recruited around 1,000 new staff last year. 500 of them were from overseas. So if you come into our hospital, you'll be cared for by staff from overseas. You'll be looked after overnight by some of the 800 staff from the Philippines who work for us. Your treatment will be delivered by a workforce that's substantially overseas at the minute. So I really agree about the importance of making sure that we recognise and welcome the contribution they make to the NHS. But as important as bringing in the right people is holding on to the people we've got, holding on to experienced people, holding on to people who do want a better offer from us as an employer. And as a trust locally, we've not been a good enough employer in the past. We still use paper records. We don't have an electronic paper record yet. We'll have one within 2 years. But if you come in for an outpatients clinic, someone will have been in the hospital at 6 a.m. going down to the basement with a plastic crate to pack it full of patient records to carry up for the outpatients clinic. And NHS England's just agreed to fund us an EPR. But we have staff coming in their 20s and 30s who sort of stare at us when we say this is the way we do business here at the minute, you know. So there's something about us being a modern, attractive employer that understands what people want from the workforce. They want decent equipment. They want enough people to do the job well. They want the training and development that speaks to their professional desire to get on at work and that speaks to their values. And actually the burnout research shows you that people don't mind working very hard when they're learning and they feel that they're doing a good job. It's when they feel that they're compromising and they're not developing that they get burnt out actually and exhausted. So there's something about recognising, people don't mind putting in a hard shift if at the end of that shift they feel as though they've done something meaningful and they've done something that's contributing to their development. So we're really focusing on holding on to folk as well as bringing in great new people. Part of holding on to folk in a trust like us is around EDI. EDI is not a nice to have thing. Actually, it's an essential component of caring for an overseas workforce, for caring for a non-white British workforce. So of those 1,000 people we brought in last year, 80% were non-white. And actually that means that when people tell us they experience discrimination and they experience bullying and unfair treatment in the workplace, it means we need to listen to that. And we need to invest in understanding the drivers of that and make sure we're addressing it. We need fewer NHS trusts who are run by white middle-aged men with grey hair. And we need leadership teams that look like the people who work in our organisations, actually. And that's an important part of what we do. And this isn't sort of fluffy stuff around the edges. This is what motivates and inspires people to do a good job. So it's really important that we're a good employer that understands the motivations of our employees and speaks to that. We need to do more about cost of living. The biggest reason for leaving our organisation at the minute is relocation. People who can't afford to live in London anymore, so they're taking them and their families and dependents and moving out of London to places that are more affordable. We also need to understand the impact of violence and aggression in the workforce. That's going through the roof just now. The fact that our ultrasound technicians have now asked for help because antenatal scans are becoming so fraught. The fact we're about to introduce body cameras in our frailty wards to help with increasing violence and aggression against staff there. We know that it's a problem in emergency departments, but violence and aggression across the organisation is increasing. And you read that Tesco's are bringing in body cams, we're bringing in body, we need to understand that and what the effect that has on people and deal with that. So we need to bring in people, be a good local employer. I accept Steve's point entirely. It's our responsibility to attract and retain people within the trust. But we also need to give them hope as well. I love working for the NHS. I think it's one of the best possible places you could work, actually. Sometimes it's maddening. Sometimes it's incredibly stressful, actually. But there's not as many jobs where when you do things right, you can make such a difference to people's lives. Monday morning I open I get some letters in, and you don't always open them with the sense of, oh, this is going to be good, because actually a lot of the post bag isn't good just now. But the first thing I opened was a card from a woman that said, my husband's just had his 80th birthday, and without Queen's Hospital he wouldn't have had it. And she listed the conditions we've treated him for and talked about the difference that the staff had made. And that was the first thing I opened this week, actually. And you have moments like that and think this is fantastic. But then yesterday I was drafting a letter to hand out via our ED staff to patients who were caring for in the corridor overnight. Say, sorry, we're caring for you in the corridor. We're doing our best for you. So there's highs and lows, but it is a wonderful, inspiring career. And we need our best and our brightest to want to come into it. We need people with empathy, with kindness. And we need, I would say this as well, we need more managers who are good at managing as well. We're hugely undermanaged as a system, actually. And if you compare us to good private sector organisations and the skills and abilities we have in our managers there, actually, more than 75% of our staff are managed at Band 7 level and below. So for those of you who don't understand the arcane NHS band systems, that's ward manager level and below. We really need to invest in those local managers so they're good, they can handle grievances without it going formal. They can support people with flexible working careers development as well. So more great managers, be a great employer, sort out the EDI stuff, get in the computer system. But actually I would love us just to be able to offer that hope and to bring in the people we need, because what a wonderful employer we are. We should be an employer of choice for great UK graduates And we should also, though, really respect and value the fantastic contribution that overseas staff make to the NHS. And I am not naively optimistic about the future of the NHS. I think it's a wonderful institution, but it's not a kind of protect at all costs sacred institution. We need to earn the public's trust and the taxpayers' faith that we're doing the very best with the investment they put into us every day. So lots to do.
Thank you very much, Matthew. And I think you gave a real sense of what you can do at a local level and what's driving you to want to do that at a local level. So really powerful to hear those reflections. I'm sure we'll be picking up on some of those through the discussion. So Susie, you have the last set of remarks. So we're going to hear from you about the importance of retention, culture and leadership in supporting the workforce.
Thanks, Sally. I think Matthew's done the job for me, and the NHS was an employer of choice for me when I joined in the 1990s, and I would echo a lot of what you've said about it being an amazing career, but we do need to really value managers and leaders in the organisation, because they help to set and develop the culture that can mean that staff can flourish. So just a few additional remarks from me. So the evidence shows that compassionate, inclusive and collective leadership, that's leading, managing in a different way by involving the workforce, is critical for both the physical and mental health and wellbeing and engagement of staff, and crucially for the delivery of high quality care. So the evidence is there. We know the way that we can manage teams effectively and retain people. And this type of leadership can directly help to address the things that the panel have been talking about, address workforce retention and particularly increase that job satisfaction, mean that when people go home from a shift, they can feel that they've done a good day's work. But to create and sustain those cultures, we do need leadership behaviours at every level of the system. So yes, there is the majority of this happens, on the day job, in the teams, in provider organisations, in GP surgeries, in community and mental health services. But it also crucially happens in the centre. So the arm's length bodies and the Department of Health and Social Care also have to display those compassionate, inclusive, collective leadership behaviours. And I'm afraid at the moment, for the work that we do, that we're privileged to do up and down the country with leaders of all of those kind of organisations, demonstrates that there is a disconnect between the espoused values of compassion and inclusion and actually what they experience on a day-to-day basis. Inquiries into the mental health and wellbeing of doctors, nurses and midwives across the UK in both 2019 and 2020 during the pandemic suggested that there are kind of key factors that really are kind of the kind of core needs of people at work, and they're around autonomy, belonging and contribution, and those are the things that kind of Matthew was saying. So again, we know what those factors are, we know what it takes to create really effective teams and for people to have joy in their work. And the latest NHS staff survey, which is a really powerful database that we have every year, really powerful data that shows us what's happening at an organisational level, but also kind of the themes that are coming through on a national level, show that despite many good examples, some great leadership and some really good organisations that are really trying to make a difference to the staff that they employ, there's still a very long way to go to improve the culture and working environment of people who are employed by the service. Just a couple of the stats from the current survey. Nearly 45% of people report feeling unwell due to work-related stress, and Steve talked about the levels of burnout. In contrast, 71% say that they get respect from their colleagues, but 11% had experienced harassment, bullying or abuse from their manager. 11% of people. And to bring this to sort of some recent research that we've been doing with the RCN Foundation, we've been following the experiences of newly qualified nurses and midwives. And we had an event a couple of weeks ago, which I have to say, attending it was incredibly emotional, listening to these nurses and midwives who are absolutely passionate about the career they've chosen. They absolutely want to stay in the service and they want to be heard. And I'm afraid to say that a lot of what they were telling us is deeply worrying. And if I can just give you a couple of examples. This is directly from a nurse. You could see that the people that I was working with weren't happy in their workplace. And as a student, I was kind of put in a box. I wasn't encouraged to speak up or to challenge poor practice or to have a voice. It was like, well, you're a student. You don't know anything. Stay there and be quiet. From another nurse, it's 4 a.m. and I'm crying in the bathroom. I'm one of the only qualified staff on the ward tonight. And one more. I was in a placement where it felt like no one who worked there really cared. They didn't care about what they were doing, and like good practice in terms of helping people fades, it was like there's a lack of empathy. So I would say, although I have hope, and I think the workforce plan is, delighted when it came. It was a long time coming, and I know the effort had gone into it, and the effort, Navina, that you say that in terms of implementation. But I have to say, today we have got thousands and thousands of staff whose experience is not a good one, and we have to act quickly and consistently to make sure that we can retain them and attract people, because I do agree it is an amazing career, and it's been my absolute privilege to work in the service and to now work alongside people in the service, and I do have hope for it, but we've got a lot of work to do.
Thanks very much, Susie. I think really important to bring the lived experience of those newly qualified staff into the room, because that's a very frank reflection of what it's like to be newly qualified in the system at the moment, and the day-to-day reality of that. So thank you. I was going to follow up with a few questions before we then bring it to the room as a whole. So actually, Susie, almost kind of bouncing off of your final point about the need for us to make progress quickly on improving the culture and the workplace experience. I think the NHS has always had a bit of a challenge about how do you move away from islands of good practice where an aspect of the workforce plan is happening somewhere, everywhere, but it's not happening everywhere all at once. What are the roles of national organisations and local organisations about identifying best practice, sharing that, rolling that out, holding peer organisations to account for making progress as well? So I suppose I'm interested in Navina and Matthew's reflections on the relative role of national and local in that, how we can get quicker at implementing best practice.
So shall I go first?
Yeah.
So I think the retention work is one good example. So if I may use that to start off with. So building on the people promise, which came out of the people plan. And then we had this exemplar, 23 trusts, and being really, really intentional about it. Bundles of interventions with evidence, with data, following it up, using improvement methodology, improvement science, and showing what works. And also, if it doesn't work, stop doing it and do something else that works. And we've got now that repository. We also know there are lots of organisations that are already doing really quite well in this space. So that's kind of at national level, kind of being able to set that, show it, support that way. The second for me is then really understanding what our structures, how they help. So at regional level, at ICBs are a fantastic opportunity to have communities of practice, collaboratives, all that sort of stuff, especially for improving culture, for organisational development, for well-being, and you bring social care in there as well. So I think we've got that structure that helps us. And then the other thing for me is being at a national level is the message that's really important about improvement is what we want to do. So NHS Impact is something that now we're really trying to push, that we're using improvement methodology in everywhere we look. And then the final thing for me, which I am determined that we will do, is that my colleagues in NHS England are on site, is that we bring all those metrics into the same place. So when we're looking at, your waiting times or the ambulance waits or, whatever the outcomes we're looking at for patients, we're also at the same time looking at the people metrics and having that level of curiosity and intention. But that's built in to how we do things.
Yes, great. Thanks, Navina. Matthew, your reflections.
We've been really focused on retention. We've reduced our turnover it was 15.5% last year. It'll be about 13% by the end of this year. We've focused on a couple of different things. One is about things like how you join the organisation. So we've now got 2 days a month, corporate induction. I welcome the staff in. And rather than a kind of teams-based experience, where when I started, the first hour and a half was fire safety, which is really important, but it's not the most welcoming induction to the thing. Now they come in and they see me, they get their badge on the same day. We've tried to take lessons from elsewhere. How do you make people feel valued? We try to do a 1-year follow-up. You're better off doing stayer interviews than exit interviews to understand why people are staying and really focus on those elements of culture and the team that hold on to people. And when people start to talk about frustrations, how do you do the flexible working stuff? It's so important. We lose good people all the time. And I find out about it and you think, why didn't we just adapt a bit around this? You know, we've just spent, I don't know what it is to hire someone these days, 15, 20 grand the cost per member of staff. We've just lost the opportunity to hold on to someone by making some small changes that hold on to them. So really data-driven understandings about what holds people and keeps them in the organisation. The encouragement and spreading a good practice. The NHS often spends a lot of time thinking about doing something when we should create an environment that's more amenable to cracking on and doing stuff, actually. I think the regulatory environment sometimes uses an excuse not to do things as well. People talk about the risks associated with doing things as a reason for not doing things, but often they're protecting a really poor state of affairs by not moving to a new thing. So something about QI, which when you were at Elft was heart and soul of improvement and turning that around. I think QI methodologies and the training and development that goes with that are really important. And encouraging autonomy within teams as well. One of the things I heard most when I got to BHRUT was people saying, what's the exec going to do about this? I said, there's 8 of us. You know, what do you mean, what are we going to do about this? You know, what are you going to do about it? You know, you're paid a lot of money to, you know, a ward manager has got a budget of about 1.5–2 million quid. You know, there's large parts of the SME world where that would be chief executive of business of their own, actually. How do we delegate authority down to the people who can make decisions that will change practice locally and encourage autonomy? Build and celebrate good practice, you know. So I like talking about the fact that we're probably one of the most improved performers in the country for A&E, admittedly from a terrible base, you know, so I'm not making great claims around that, you know. But actually in surgery, we're you know, regularly in the top 3 in London, actually, for our elective performance, you know, and really celebrating when we're doing great stuff and promoting that and telling the staff that we value it. And also curiosity as well. I was Chief Executive of Mental Health Trust before I went to the acute. We've got so few people who work between the different sectors. You know, I used to run the Princess Royal down in Bromley, and we had a mental health trust on the same site as us. I never went in there until I became the chief exec of it. I didn't understand how they worked. They didn't understand how we worked. And we really lack curiosity. In the acute sector, we lack curiosity about primary care. We lack curiosity about social care. We've got to encourage more people to work between different parts of the sector because the patients don't exist in these little specialist pockets we've created. And yet we design far too many of our structures and develop people's careers far too much in those little pockets.
Thanks very much, Matthew. I think some really good steps there to how we can have best practice and have improvement right across the piece. So a data-driven understanding of what's happening in your local area, crack on and do it. I like the concept of that. Autonomy, so delegating more authority to more celebrating good practice, and then that final point about curiosity about others, really, really important.
That,
so
that includes
thank you.
outside the NHS.
Yeah.
Because people don't look at us just as the NHS. They compare us to the other employers that want them at the minute.
Yeah.
You know, and I see as I drive into work, I see the double-decker buses that are taking everyone out to Amazon at Tilbury every day, you know, piling on with people who are going on making the choice to work in other careers at the minute than social care and health. It's not just good to be a good NHS trust, you've got to look at what a good local employers are offering instead. And we've got to be not just the best in the NHS, we've got to be the best employer that people can choose in our part of London.
Agree. Susie, you wanted to come in.
So I agree with everything's been said. But what I was hearing consistently there is about the role modelling of leaders and managers. And we need that at every level. You know, it's about showing up. It's about showing interest in the people that you're working with. It's not about being a remote figure. And again, I'm afraid that what we hear time and time again, particularly from newly qualified staff, is they've got no idea who their manager is. They've got no idea who the trust chief exec is. So there's something about us being visible. I take your point, Matthew, absolutely, about there only being 8 of you, but it's kind of what you expect of your general managers and what you expect of your clinical leaders to make sure that actually people know who they're connected to and know who's in their team.
Great, thank you. So just one final question from me before we come to the floor, and I wanted to come to Steve first on this, which is just really to reflect that in some of what's been said today, it's the importance of roles other than doctors and nurses. So whether that's managers, leaders, roles that can allow understanding and improvement on EDI. So a kind of concept that the NHS team is a much wider group of people than doctors and nurses. Mm-hmm. But politicians can be really quite obsessed with doctors and nurses. So how can we kind of win the argument about that actually one day a politician should stand up and say, yes, I want 50,000 more nurses, but I also want 10,000 more managers? Can you see a world where that might happen? And how could we make that happen?
Well, doctors and nurses are a bit like bobbies on the beat, aren't they? You know, they go well in manifestos. But to be fair to, you know, when I was a health minister and, you know, the previous set of health ministers, Steve Barclay, you know, they were always talking about the additional roles. You know, and as a constituency MP, you're sometimes asked, you know, I want to see see you and you can't see them at that time, and they all, who can I see your deputy, or that it doesn't exist. But you see in primary care, for instance, when people say, I can't see my GP, well, very often you don't need to see your GP. There are many other roles within the primary care family. It might be the pharmacist that will do a medicine use review, for instance. You're right, the more that language enters the lexicon, the more that the public will accept that and understand that. Because of course there are times when you need to see the actual GP, but there are many other times when you can see a practice nurse or you can see a pharmacist. And often people just want the reassurance of talking to somebody in the primary care family. And as long as that team is linked together enough to be able to pass it to a more senior clinical level so that patient safety is protected, then I agree. Just going back to this issue about retention in the Royal, I'm doing something called the Armed Forces Parliamentary Scheme at the moment. I'm doing the Royal Navy side of it, and they have a thing in the Royal Navy called join well, serve well, leave well, which is exactly what it says on the tin. I'm not sure that we're very good at that in the NHS. So go to your point about when people arrive, they're sort of lost in this organisation, and people will leave because it's a mobile workforce, and that's understandable. But when people leave well, you need to make sure that they pass on what they've learned. And the workforce plan talks about recently retired doctors coming back. But if they don't leave well, it's very unlikely that they're going to want to do that. Just one thing in the workforce plan that I always I carry my copy around like a complete sado. But one thing I know. I always find this bit quite interesting. See, this is on page 61. Every staff member should be given the opportunity for regular conversations to discuss their well-being and what will keep them in work, including discussions about pension flexibilities, flexible working options, and health and well-being. That's the sort of thing that a top drawer blue chip private company would struggle to do. I struggle to see how the NHS is going to do that, but Naveena's going to tell me that there's a plan and that point 15 on page 61 is real, and I really hope so, because I think actually that's probably one of the most important lines in the workforce plan.
You're absolutely right.
Do you want a right of reply?
So I think I'm so glad you picked that particular line, and by the way, I have that in my handbag as well.
Yeah.
So the reason that's there is because we've seen it happening and it works, and we know how it can happen, and it can happen in a systematic way, and it can be built into our systems and processes, and we know that. So the question, and that is part of the retention exemplar work that we do. It's part of the bundles that we offer people. So I think it's not an unreasonable expectation. Also, our business is care. So we are caring for people. It is really tough to do that. And therefore, you do need that space. So it's something that I think we will be wanting to embed all the way across.
I was glad to hear you mention ICBs and
Yes.
ICSs, and we did a big piece of work that came out around the same time. The government responded to it at the same time as they responded to Pat Hewitt's report on ICSs, and Pat and I then did a bit of a roadshow together, including at Confed in Manchester, talking about it. And our report was called Autonomy versus Accountability. And that's the real challenge, because in many ways the NHS is a brand with a logo. It is not a national health service. It's lots of different systems, and within those systems are lots of different trusts, whether they be community, acute or mental health. And so I don't think we should get so hung up on there being differences sometimes. Best practice should be what makes sense, not what's enforced. But I am concerned about leadership within systems. I am concerned about we are concerned about leadership within ICPs, and we are going to do a post-LETB piece of work on leadership, which I think one of the greatest regrets out of the LETB response was this kind of setup of antagonism between managers and clinicians, as if they're not part of the same team. I would deign to suggest that that's what went wrong at the Countess of Chester, and if we set that up as an argument between managers and clinicians in the rest of the NHS, we'd be doing it a great disservice. I would have thought in your organisation it's one team, right?
Yeah, and I mean we talk about this managers clinicians thing. Most of our managers are clinical,
Yeah.
You know,
Over half of the NHS
Yeah.
trusts leaders in London are clinical background.
Yeah, and we've really tried to push that actually. You know, I mean, we've recently actually done a restructure that's taken out non-clinical management posts and created more clinical management posts because they can make a really big difference actually. But the false opposition we create is sometimes really quite difficult in that space. So I think investing in that's really important.
Absolutely. Great, thank you. I'm going to come to the room now because we've been having a fascinating conversation, but I'm just thinking we risk not having time for conversation. So hands up and I will take 2 or 3 questions at once. So we'll go Leonora there, Rob, and then front row, and we'll do that. So if you could introduce yourself and short questions. Thank you.
Thank you. I'm Leonora Finley. My background's palliative medicine, and I'm a crossbench peer. That's fascinating. Thank you, Susie, for being so frank and honest about what's happening. We live in a 24/7 world, and yet none of you have spoken about managers being in there during the night on a regular basis, working alongside. So we have clinical managers, but sometimes they've left the front line to be managers and have stopped doing the 7-day working and being there at night. And without that, I don't really see how you can adequately support the clinical staff in the changing scenario. And picking up on Matthew's point about risk, there is a risk in not doing things, obviously, as well as in doing things. But I think risk assessment is something which the balance has been got wrong generally across the NHS and in the conversation with the public. So the public don't understand that there is a risk attached to everything and they're looking for a zero risk environment when they become ill. And my last question really over the workforce is what conversations you've had with the colleges over changing training so that people don't get stuck in one line but can actually move sideways rapidly, including between general practice and hospital medicine and aspects of care, so they can develop their skills right up until the day they retire, because training doesn't stop when you finish your postgraduate training, it stops when you come off the register.
Great, thank you. And we'll go Rob.
Exec of NHS West Yorkshire. Sorry, I think you missed the beginning of that. Hello, my name's Rob. I'm the Chief Exec of NHS West Yorkshire. Really great to hear all the things on the panel, particularly around EDI, around the fact that some of our staff have a very different experience because of the colour of their skin. And Susie's, disgraceful figures around bullying and harassment at the NHS are exacerbated if you come from a Black Caribbean, Black African, Pakistani or Bangladeshi heritage. So we know that and we need to do something about it. And I think it's that point about difference that I wanted to explore really. I do think that there's a great deal of opportunity with local employers supported by the system working in a context of kindness, compassion and values-based leadership to make a big and substantial difference. Just yesterday at our partnership board meeting in West Yorkshire, we heard about the Leeds Health and Care Academy, where after a year we have 95% retention rate for people who've been recruited from underserved communities and people furthest from employment because of the approach that's taken to their employment and support. But those sorts of arrangements need to recognise that there are differences around the country. So in West Yorkshire we have 1% higher sickness than the England average. That doesn't sound much, but it's 1,000 less staff every day in work in West Yorkshire. So how do we recognise, as Steve Bryan says, that the NHS is a system and support systems to support employers to make sure that they're delivering the best possible opportunities for people to be employed in the NHS?
Thank you, Rob. Then we'll go this gentleman at the front and then we'll be coming to the panel.
Tom Hayhoe, serial trust chair, and before that, in the old days, a health authority deputy chair. We could boil the ocean on this one, to use a phrase of a chief executive I used to work with, was one of her favourites. And I could ask questions for the rest of the day of all of you and make further comments. But I want to just focus on one. A few years ago, the reason I'm sitting in the front row is because I'm deaf. A few years ago, I established or co-founded the Disabled NHS Directors Network. And one of our roles has been sort of championing the interests of disabled employees and people with long-term conditions in the workforce. And if there's one particular area which I hope will get adequate emphasis in all this, because it's related to the retention question, is that we pay enough attention to what we do to support staff with disabilities or long-term conditions. We set the network up because there were precious few people in both executive or non-executive board roles with disabilities, compared actually to the private sector, employment as a whole, and so on. And we lose people unnecessarily because we don't do what would be cost effective. No, one of the first things you recognise if you've got a disability is you can't do everything. But we do lose a significant proportion, and it will only get worse as our population gets a bit older. So that's just the one thing which, because I'd love to spend the rest of the day talking about this agenda.
Yeah, we do need to make sure our panellists can head off elsewhere. So thank you. Some really good questions. I don't think we're going to have everybody in the panel respond to every question, so I'm going to try and do a bit of direction, if that's okay. So Matthew, I wondered if you could pick up Leonora's questions, particularly about kind of management and leadership in a 24/7 world. And then I might also ask you to start to reflect on the support for staff with disability and long-term conditions, and I'll probably come to you on that one as well, Navina.
Okay.
So Matthew.
So I think that's a really good point. And then the number of both clinical rotas and non-clinical rotas I look at, where I sort of point out that the attendances start around here when everyone seems to be going home. You know, and I don't know if you remember the NatWest adverts in the 80s when they changed banking from Monday to Friday to start opening on Saturday mornings. And I think we've still got too many services that are heavily weighted towards providing a 9 till 5 service. And we know from when people arrive in hospital that if you arrive in the afternoon, you're going to face a far longer wait than someone that comes in the morning. I do think we need clinical managers and non-clinical managers alongside that. You know, in on the weekends, people value it. People like to see you walking down into the A&E at night when the staff are there and saying, we recognise this is tough, actually. So I think that's a really important point. And I don't think we get that right at the minute, actually. And I think it's a challenge for the entire workforce that you're entirely right to pick up on. I think also the point about disabled staff, we've just published a workforce adjustment policy in our trust. In our staff survey last year, the single poorest experience of work was our disabled staff, actually. So as a response to that, we've published the workforce. Managers worry about employing disabled people. I think we've got to be honest about that. I think if you understand someone's got a disability or a chronic mental health problem, etc., people worry about employing them. They don't understand what reasonable adjustments are. I worked for the Multiple Sclerosis Society for 5 years, and I've seen a lot of this from the other side. So you have to really support people to have the courage to employ people who are different and to celebrate that difference. We've got Project Search at work at the minute, which brings in people with learning difficulties and others into work. And actually the staff are responding so well to it, but you've got to help them make that choice. We've just appointed a full-time workplace disability coordinator as well to support people with that. Hello to Rose, she'll be very excited about this, you know. But for us, actually, you've got to get the value out of that, and that's what helps with the sickness point that Rob brought up, actually. You know, really understanding how you get the most out of the workforce is so important.
You might want to build on the point about support for staff who are disabled or with long-term conditions. Also wanted you to pick up the question about colleges, please.
Thank you. We recognise absolutely from our work with WDES, Workforce Disability Equality Standard, but also the work with the Disabled Directors Network, and we know we are losing staff, retention work, because we are basically having those conversations. We can't accommodate your needs, well, I'll have to leave then. So, and probably go and work for an agency and come back and cost us even more. So building that to the cost, and we are losing skills. So building that into the People Promise has that. The other is the EDI improvement plan, very specifically asks our leadership in particular to look at their needs in their organisations, and it covers our staff with disability. The final thing I'll say there is that it took me a long time to actually say that I have long-term conditions and have a disability, which is not visible. And when I did that in the trust, and when my chair and I did it together, and then two other board members actually said so and put it on ESR. And then it opened up a whole other conversation in our organisation. And to your point about supporting managers, our managers are asked to do a lot that we don't necessarily support them to do. And, you know, flexible working, how do you manage a rota when everybody wants flexible working? But you can do it, and there are lots of ways. So that's a really important point. The colleges question. We have been really fortunate throughout the development of the plan and now in its delivery to have the colleges right alongside us in working in this space. Every single college is up for reform. Every single college works with us on their curriculum, on how we train, on differential attainment, sexual safety for our trainees, discrimination and reviewing, you know, really, do we really need to do all those steps now? Do we really need to train and learn the way we do? Currently, one of the things that the trainees have fed back to us is the rotations. Do they really need to rotate in the way we've asked them to all these years? Because can they develop those same competencies and skills, but they don't have to move in the way that they used to? Because life has changed, services have changed, methods of learning have changed. So that is work that we're doing right now with the colleges, and we're really grateful for the support we've got in that space.
Thank you.
Can I just add that on the colleges, they come in to see me 4 times a year, a selection of the presidents of the colleges, and actually number 10 NHS England did really well on bringing the colleges with them on the workforce plan and them owning it. So actually I think they really do buy into it and own it. On the disability point, actually last Tuesday morning I spoke at length about this at a disability summit that was organised by Confed. It's a big virtual summit, so it's all completely up there online at the moment. And what I learnt from it, in many ways, it was the low-hanging fruit of retention, because it wasn't really big ticket items like, you know, well, I just can't make the sums add up on pay. It was actually quite low-hanging fruit items on just pure quality of work-life issues. And it didn't seem to me that there was always an awful lot that needed to be done to make sure that they felt valued and and loved, and therefore wanted to stay within the employer. So then that comes back to my nerdy point on paragraph 15 about those conversations about health and well-being with employers, because if they're not happening, then they just think, oh well, I'm going to have to leave. But it was a Confed event. It was called Disability Summit. It was last Tuesday morning.
Susie wants to come in on that, and then we still have Rob's question to answer, so I will come back to that in a moment.
A brilliant example that I saw in Leeds a couple of weeks ago around disability is with a trust who's proactively employing people with learning disability to be part of the team in the Learning Disability Service. I was talking to some amazing people in that team, and they have a lot that they could teach very senior people in the health service about how to be a team. I have to say, I said that to them at the time, and I would encourage people to go out and have a look at where this is being done really well. There are really great examples, and it's not difficult to do.
Yeah, thank you. So I'm going to direct Rob's question to Steve and Susie, and then I'm going to try and do another quick round of 2 questions. But Rob spoke very powerfully about the particular context of his system, but really what was the core part of that question was about actually we shouldn't pretend that we should have everything exactly the same everywhere across the country. So I suppose I'm interested in the role of Parliament and politicians, the role of organisations independent like the King's Fund in giving ministers the confidence about how can you demonstrate change in a way that isn't one size fits all and it's the same everywhere. So that kind of, if you like, that autonomy versus accountability, it's not versus, it's how can you have accountability in a way that also encourages appropriate local responses.
That's what, I mean, neither should we pretend, nor is it desirable for it to be the same everywhere, nor would it be clinically appropriate for it to be the same everywhere. I understand, you know, as a health minister, you know, you always want things to be uniform because then somebody shouts postcode lottery. But actually, you know, in the area of public health that I used to be responsible for, you know, there are different smoking rates in Blackpool than they are in Winchester, where I represent. Therefore, it requires a different response on a public health policy level. And so, you know, we're just doing everyone a complete disservice to try to listen to the dog whistle of postcode lottery, because sometimes there needs to be difference, and I understand for ministers it's very hard to have the confidence to do that. But that's why we did our autonomy and accountability in the report and the act of Parliament that was the Health and Care Act 2022, wasn't it? That bill, as did the original Health and Care Act that Lansley did, that builds in local accountability through upper tier authorities and through health and care select committees at local authority level who are meant to hold local leaders to account. It can't. One of the most frustrating things about being a health minister is the same as I'm sure being a schools minister, is that you're not in control of every single part of the system, and one of the reasons I'd love to have gone back before I leave Parliament next year is that with maturity you learn that.
Susie, quick reflections on that before we go.
I mean, I was an NHS management trainee 30 years ago, and we were having this debate then. I remember it vividly with my fellow trainees. I think you were asking about the role of organisations like the Fund. I think our job is to work alongside leaders and managers and help bring forward the evidence for what works in local contexts. And I think, to pick up on Roz's point, it's also about a really effective relationship between the ICSs and the regional teams that are part of the national system to make sure that there is a true, deep understanding of what's happening locally and what the local needs are, and that those regional teams are embedded locally, that they don't sit, just in London. So it's about getting out and about and actually being part of the system, I think. But I think that debate will continue on. I'm sure trainees who have just started now will be having that same debate in another 30 years.
Yeah, thank you. I know Navina wants to quickly respond. Can I just ask my mic holders that we've got questions at the back, the bottom. So Navina, quickly.
Follows on from Susie's point, which is about warranted variation. And in the world of improvement, warranted variation is something that we want to hold on to. It's really important, but we need to use the data, we need to be able to explain it for everyone to be able to see why, and it needs to be in the interest of improvement, not an excuse. Yeah. So the relationship with ICBs, I think in particular, are crucial in this space.
Great. Thank you. A really important point about that warranted versus unwarranted. Right, I think I've got time to take two questions. So we've got one at the back, and then the gentleman in the blue jumper are the two that have been hands up the most. As short as possible in your questions, please, because I've been poor with timekeeping.
Chief Executive, Royal Society for Public Health. So our members tell us all the time that they want careers as generalist specialists, not as specialists, and we've gone the opposite way. My question is actually at the other end of the spectrum, which is, do the panel have a view on how we actually value, support and create careers, not for the nurses and doctors, but for the porters, the cleaners and the people that really run our hospitals?
Great question. And then this gentleman.
Nick Pearl, I'm Chief Executive of the Society of Occupational Medicine. We've done various reports on burnout this summer and mental health of nurses and doctors. I suppose the panel just spoke so wisely around an evidence-based approach, and we do still hear, we had a meeting recently where an occupational health physiotherapist was saying 140,000 quid was being spent on massage chairs, and she could have spent that on a kind of dedicated evidence-based sort of focus on kind of musculoskeletal issues. So I suppose it's not really a question, it's just a well done panel, and we have to follow an evidence-based approach. That is so important, and not only for occupational health and well-being, but some sort of serious events. We've got an event tomorrow around effective suicide on people who Royal College of Psychiatrists, and you just have to follow that data-led, evidence-based focus, and you can't go on a whim. It's very easy in this area in terms of kind of occupational health and well-being to kind of. I think that the trust was sort of led by a director kind of pushed in this massage chair thing, rather than listening to occupational health and well-being people who understand what works, and as you do too. So it's not really a question, it's just a plea for that focus, and obviously for, well done Navina and the work that's been happening in terms of growing occupational health and well-being and getting those teams in place. Particularly you need those clinician support. I think doctors, nurses and other clinicians really value other clinicians helping them, occupational health clinicians helping them. So that peer support is so important.
Thank you. One kind of question, then a broad reflection there. So in terms of the question, the wider family that makes hospitals and healthcare services run, cleaners, porters, all of that, sometimes with an extra complication that they might be an outsourced group of staff as well. So I'm probably going to come to Matthew and Navina on how we can make sure workforce improvement is for the entire family of our workforce and not just some groups.
Yeah, I mean, it has to be, doesn't it? And it's, we're a big local employer. Lots of our staff live and work locally, and we're the hospital that their families are treated in. Lots of them were born there. You know, and it's a really important point that we need to recruit more people. I mean, you hear at all ends. Queen Mary's University London have done some fantastic work bringing people into health who've got no one in their family who's ever worked in healthcare before, actually, and they're supporting people from all kinds of different backgrounds, whether that's into medicine or other healthcare professions. Within the Trust, I mean, we're a registered training provider now for apprenticeships, so we're registered with Ofsted as a training provider. We're really pushing apprenticeships as options, and there's nothing delights me more than when you see someone who joined us as a Band 2 or a Band 3 who's now a Band 7 or a Band 8, and we celebrate those career pathways within the Trusts. You know, around half our workforce are not clinical. You know, so there's people from finance, HR, IT increasingly, now that we're getting rid of the paper. You know, and it's about letting people know that whatever you do, there'll be a career within the NHS that'll suit you. And they don't need to stay in our trust necessarily. They might want to go and work at Bart's for a bit, as long as they come back to us eventually when they've got the skills they want. You know, but we need to create careers for life within the NHS, and by being better, more flexible employers, we can do that. On the evidence-based point, really important. You can see how something gimmicky is often attractive as a quick fix. Most of the fixes in the NHS that are evidence-based take time, they take effort, and lots of the NHS work is doing the same thing you did yesterday, slightly better each day. The risk of poorly evidenced interventions, particularly around things like mental health in the workplace, you know, single debriefs rather than structured debrief sessions and that. You know, not everyone needs to talk to a psychologist. Some people just need time and space. You know, really understanding the research around occupational health is such an important part of work, and the evidence has to lead us down the right path with these things. And most of those answers take more investment, more time, but deliver better results.
Thank you. Navina.
So I think that the workforce plan is the beginning of making us think about the whole of our workforce. And definitely we've got the digital workforce plan, we've got thinking around the futures, which is the HR profession. We've already had lots of people talk to us about, for example, our estates experts, you know, and then of course we've got management training, and we'll gradually start to bring that all together. But your point was about lots of other roles for whom we couldn't survive. And in my view, in my mind, I would really look to local systems to help us to think it through, because that so much depends, because you're mostly going to be recruiting from your local communities. And again, this comes back to a real belief for me in an anchor system, and how actually you're understanding your local labour market, you're understanding people's aspirations, and you really know how to bring them in. I also see this as a pipeline opportunity. So through apprenticeships and elsewhere, we have wonderful stories of people who say they started as a porter, they started and then really got drawn. It's a way of drawing people into our NHS kind of family, if you like. But again, that first encounter is so important. So I actually see this as a pipeline opportunity as much as anything else.
Great, thank you.
I really love the apprenticeship thing you're talking about. For the I'm not sure they're the people that really run the hospitals. Everybody really runs the hospitals. That's the point. It doesn't work without any of them. But you know, I was going on about the productivity assessment earlier. You know, which is in the workforce plan says, you know, up to a range of 1.5% to 2%. Well, the productivity of a hospital, if the patient is not in the right place at the right time, then therefore the porter does hold the key to everything. Absolutely. Could I just make one plug, seeing as you very kindly asked me? So I do a podcast every other week called Prevention is the New Cure with Dr. Helen Stokes-Lampard, who many people will know. And the reason I put a lot of effort into doing that and promote a lot of the work that we're doing on Select Committee is that I have a very clear view that the NHS demand is outstripping supply. And we will never have enough money and we will never have enough staff if we don't deal with demand and supply. And therefore, that's why we are spending so much time as Select Committee doing our prevention inquiry, and unless we are serious about stemming the demand through the prevention of ill health, you can write 1,000 workforce plans and you can double the budget and it'll never be enough.
And we completely agree with that. So at the King's Fund we've got 3 clear asks really as we go into an election year about what do political parties need to address. One is how to make health and care an attractive career, to build on the workforce plan, to really focus on retention. One is how to ensure we can rebalance between hospitals and other parts of the health and care system, particularly in the community. And then the third is how to really make progress on tackling the biggest risk factors that can change the kind of future burden of disease.
I had a big.
so yeah,
I
completely
chaired a
agree.
big event in Parliament last night on CBD with Ram Prakash, the cricketer, and we would. The amount of savings that could bring to people's lives and to bottom line of the NHS are absolutely huge. So I know you get it, and I know it's really difficult. And you know, Caroline Flint brought in the smoking ban. She could never have done what this government's now doing on the wider smoking changes, because she had political space within which she could move on smoking and banning smoking in public places. Every government has the political space, limited political space, in which it can move on so-called nanny state. My view is, in a publicly funded health system, you have a right, and I would argue a responsibility, to intervene in public health, because if you don't, it's the taxpayer funded system that picks up the tab.
I think we're at risk of moving into a second breakfast event there. So I'm gonna, we are pretty close to time, so I was gonna ask for final reflections, but actually I think we're gonna struggle to do that and allow people to head off to their days. So I just wanted to thank the panellists for really honest, helpful reflections covering a really broad range of issues around how we can really support the NHS to be a first-class choice for people to work and develop their careers in. I think a real sense of there is hope, there is good practice happening, but also a bit of a reality check as well that that is not the experience that everybody is getting in the NHS at the moment, and a real kind of need to address that quickly to mean that we are supporting our kind of new generation of staff as well as retaining our more experienced staff. So thank you very much to our panellists, and thank you to our audience for battling in on difficult transport and for asking good questions today. In terms of the King's Fund, as I was able to say because of Steve's remarks, we are thinking broadly about 3 areas on the election. So we'll be having a series of breakfast events on those kind of topics. So the next one on our election topics will be around shifting or changing the balance of care between hospitals and the community sector. That will be early in the new year. We held one on prevention in the summer. And we have also got an additional breakfast event next week on social care, and particularly how social care can support improved discharges from hospitals. So if you're interested in that, please do come along. It's a virtual one next week, so I say come along. Bring your own tea, coffee, your own mini pastries to a computer screen near you. But thank you very much for your time. Yeah, thank you. Thank you.